Welcome to the show, Talk with Your Doc. I am Dr. Prashant Jani, and with us is today Dr. Margaret Anthes. She is a radiation oncologist and head of the radiation therapy department at Thunder Bay Regional Health Science Center in Thunder Bay, Ontario, Canada. And today we are going to talk about role of radiation therapy in breast cancer. Breast cancer is one of the most common type of cancers all over the world. About 1 in 8 women develops breast cancer. Every year in Canada, 26,000 women are diagnosed with breast cancer, which means about 72 women are diagnosed with new breast cancer every single day in Canada. In one of our previous episodes, we talked about various risk factors for the breast cancer, various modalities of treatment for the breast cancer, and today we are going to talk in depth about role of radiation therapy in the breast cancer, and Dr. Margaret Anthes is going to guide us about that. Thank you, Dr. Anthes, for coming to the show again.
It's my pleasure to be here.
Very nice to have you. Please tell us what is radiation therapy and how does it help in breast cancer?
Right. Radiation is use of high energy X-rays or photons, electrons to treat cancer. We know that cancer cells grow more rapidly than normal cells and are more susceptible to radiation. It's actually the DNA that's damaged by the radiation beam, and in being damaged, the cancer cells, the growth will halt, and cancer slowly eradicated by the radiation.
So radiation will kill those rapidly growing cancer cells.
Right.
So do all the patients with breast cancer get the radiation therapy?
No, not all patients, but many breast cancer patients are treated with radiation. There's different ways breast cancer patients are treated with radiation.
So means ways means like mode of giving the radiation therapy is different?
Right, that's right. There's 3 different ways that radiation can be given. One is external beam radiation, and that's given via a large machine called a linear accelerator. So there's an X-ray that comes from outside of the patient and goes in the patient. There's internal radiation, where a patient would have a catheter put into a tissue of the body, such as the breast, and then radiation beads go into the catheter and radiate from the inside out. And some patients would even have intraoperative radiation, where the doctor, the radiation oncologist, would be present at the time of surgery and put radiation right into the operative site.
Okay. So one you said externally given, one type of radiation is where they put the radiation material inside the tissue.
Right.
And third one you said is during the treatment.
Right.
So which one is used for what type of patients now? How do we
Well,
select?
in Thunder Bay right now, for breast cancer patients, is what we're talking about, patients have external radiation via what's called a linear accelerator, which is a large high energy X-ray machine.
Okay. Now, why is, once the surgery is done, what is the role of radiation after the surgery?
Right. Well, there's different types of surgery for breast cancer. Women may have a lumpectomy, which is removal of the tumor with a margin of tissue around it. Other patients may have a mastectomy. In the lumpectomy, and all patients with breast cancer would also have the lymph node dissection, usually a sentinel lymph node dissection, where they take out the main draining lymph node or lymph nodes. So those would be the surgery, and then radiation is given to the breast or the chest wall after the surgery to minimize the chance of the cancer coming back.
So even though the breast cancer margins are negative during the surgery, in the pathology report it says margins are negative, still you give the breast radiation?
Right,
to the breast
so that's a really good question, because it seems like the breast tumor is completely removed. Why does the patient need radiation? And the reason is that we know from studies and from large series of patients that 25% of patients with an early tumor and negative margins will still have a relapse in the breast if we don't do anything else. So following a standard course of radiation, the patient would have down to a 5% chance of relapse. We also know even if the breast comes off, we're still talking a 4% chance of relapse. So there's no difference between a patient who's had a mastectomy and lumpectomy plus radiation.
Right. So even though the margins are negative or entire breast is removed, there is a 4% chance that the cancer can come back. Right. And to prevent that 4% chance, we give the radiation.
Well, it's actually more the, if you take the breast off, if you take the lump out, there's the 25% chance it can come back within the breast. You radiate and it's down to 4%.
4%, okay.
So we're 4 or 5%, we're happy with that. If you take the breast off, you still have this 4%.
So if we don't give the radiation, then there is a 25% chance of recurrence then.
So 1 in 4 women will have a recurrence without radiation.
Without radiation. So all the type of breast cancer, radiation is very useful to prevent the recurrence of the...
Right.
So
it's not all the time. Like if a patient has a mastectomy for a small unifocal tumor, one tumor with no lymph nodes and the margins are clear, we don't give those patients radiation.
okay.
So it's only if the patient has a breast there, we would give radiation for a unifocal tumor, or if a patient has lymph nodes involved following a mastectomy, that patient would have radiation.
So Dr. Anthes, some of the patients, they receive chemotherapy after the surgery and then they receive the radiation. So what is the sequence of the treatment? Is it radiation followed by chemotherapy, or chemotherapy and radiation goes together, or how does that work?
For patients who need chemotherapy after surgery, radiation is the third treatment that's given. So the radiation would come after the completion of chemotherapy. What we do is we wait about 1 month after the chemotherapy is complete before starting the radiation.
Okay, so surgery, then chemotherapy, and then after a 1 month gap, we give radiation then.
Yes. When patients need chemotherapy, they're considered higher risk because of the pathology. Perhaps they have lymph nodes involved, perhaps the grade of the tumor is higher, the risk factors are higher. So we're most worried about their entire body. So if cancer cells got into the bloodstream and are, can spread in the bloodstream and spread to organs. So the first thing that we consider is the entire body, and thus chemotherapy first.
Yes.
The second priority then is the breast, attention to the breast where the tumor started, and lowering that risk, so that would come after chemotherapy.
Okay. Now, how long is this radiation therapy duration?
Radiation is given over about 4 to 6 weeks when it's given as preventative treatment for breast cancer.
Okay, so chemotherapy, then 1 month gap, and then about 6 weeks of radiation then.
Well, it could be 3 weeks of radiation.
3 weeks.
It depends on different factors. So if we're only treating the breast, that would be 3 weeks.
Okay.
Depending on patient size. So sometimes if the patient is larger, we would give more radiation because we give radiation a little bit slower.
Okay.
If the breast size is larger. But if it's a small breast, it would be 3 weeks, 16 treatments. If we're treating lymph nodes as well as breast or chest wall, that's usually given over about 5 weeks. And if we have to give extra radiation because of a close margin, that would take it out to 6 weeks.
Okay. We'll take a short break and we'll continue with the discussion of the radiation therapy. Please stay back for the next part. Thank you. Welcome back to the show, Talk with Your Doc, and today we have Dr. Margaret Anthes with us, and we are talking about role of radiation therapy in the breast cancer. Dr. Anthes, you were mentioning about different types of treatment. So first is surgery, followed by chemotherapy, followed by radiation. So question is, why don't we give radiation before the chemotherapy?
Well, with breast cancer, when patients need chemotherapy, it's a more aggressive breast cancer because of certain characteristics, whether it be the size of the tumor, lymph nodes involved, genetic characteristics of the tumor. And in that case, there's a higher risk that the patient would have a systemic breast cancer relapse, meaning relapse in the organs. So chemotherapy will get into the system and travel all over the body. And that's our first priority, and that's why we give chemotherapy first. And then after that, we concentrate on the breast, because that's the secondary treatment. Yeah. So we give chemotherapy before the breast radiation.
And once the patient goes for the radiation therapy, who are the team members in the radiation treatment?
Well, there is many people working in the radiation department, all with distinct roles, but all working together as a cohesive team. Mm-hmm. Of course, there's the radiation oncologist, the doctor who assesses the patient and determines if radiation would help in the particular cancer. And then there's the medical physicists and the dosimetrists who help plan the radiation, do the calculations, keep the radiation machines functioning. There's a radiation oncology nurse who assists the doctor and assesses the patient's needs, and radiation therapists who actually treat the patients on the machines, deliver the treatment.
So quite a few people are involved in the treatment of the single patient for radiation therapy.
Yes, it's definitely a team approach with radiation. The doctor can't function alone.
Now, when a patient is first visiting a radiation clinic, what can they expect on their first visit?
Well, on the first visit at the cancer clinic in Thunder Bay, patients have a tour. So they start with a tour so that they understand the physical layout of the clinic. And then next they will meet a nurse.
Okay.
And the nurse will take their medical history. And after that, the doctor comes in, and the doctor will review the medical history from the nurse and examine the patient, and then determine if further testing is needed, determine if radiation would be helpful.
Right. So then what happens once the orientation is given to the patient? Then what happens the next?
Right. So let's say the patient does need radiation, and we'll say our breast cancer patient comes in and needs adjuvant radiation. The patient would come in for what we call a CT simulation.
Okay.
And a CT simulation, they're in the same position that they would get their radiation. They go through the CT scanner, and then the images go to the computer, and then the radiation oncologist or the radiation doctor will map out what needs to be treated. And from there, the CT images go on to the physics department, where the dosimetrist comes up with a radiation plan, checked by a medical physicist.
Right.
And then the patient comes for treatment.
When the patient is being used radiation to the breast, will heart and lung receive the radiation?
That's always a concern with our patients, that we don't over-treat normal tissues.
Yes.
So with the breast, it's if you go down below the chest wall, you have the lungs and the heart.
Yes.
And you don't want to overdose either with radiation. But with the CT simulation, when we plan with CT scans, we can map out where the heart and lungs are sitting and make sure that we do not give excess radiation to those structures.
So heart and lungs are safe while the breast is receiving
They are. A little bit of
radiation.
scattered radiation will go to the heart and lungs, and we have numbers that we look at. So we keep the heart dose and the dose to the lungs as low as possible.
Okay. Now, what sort of care a patient has to take during the radiation treatment?
Well, first of all, I should mention to you that radiation, it's a painless thing.
Okay.
It doesn't hurt to have the radiation treatment, and the side effects are gradual that develop.
So how long is the course of radiation treatment then?
Well, the course of radiation treatment is somewhere between 3 and 6 weeks.
And each day patient has to come, or they have to come once a week or twice a week, or
Right.
how often they come?
So the patients are treated generally Monday to Friday, but there's different amounts of time that a patient would need radiation. So it could be as simple as something like one treatment that a patient gets, and that would be a patient where the cancer perhaps has spread into the bone or spread to another part of the body. The patient may come for one single treatment to a bony site. But if we're talking about radiation to the breast or to the breast and lymph nodes, it's about a 3 to 6 week period of time. And with a 3 week period of time, it's like Monday to Friday for 3 weeks.
Okay.
If it's 5 weeks, it's the same thing. It's 25 treatments, Monday to Friday for 5 weeks.
So they have to come every day
Right.
for so many days then. Now you
Right.
said that, you mentioned that radiation is a painless treatment.
Right.
But does radiation have any other side effects?
Right. So the side effects from the radiation treatment are slow and gradual as you go through the treatment. So for the first week or two of radiation, there may be fairly minimal side effects, but following that the side effects start to occur. So at first, the patient may notice a little bit of itching, for example, of a breast, irritation of skin. The skin can become red.
That's at the site of radiation.
Right. So when we treat for, like for example, a breast, we would treat the entire breast with radiation. So the patient may notice marked skin redness.
Right.
And it's really individual, and sometimes it's hard to know which patient will have more of a severe reaction and which patient will not have quite as bad reaction.
So redness of the skin or itching sensation at the site of radiation, is that the common one, right?
That's common. That's called radiation dermatitis.
Okay. Any other side effects of radiation?
Well, if we're talking to the breast, there's what we call acute side effects that occur during radiation or shortly after radiation, and that would be the radiation dermatitis, the breast tenderness, chest wall tenderness, tiredness. That's another early side effect of radiation. Side effects that occur a little bit down the road, intermediate, would be something like very rare pneumonitis from radiation to a little bit of the underlying lung. The chance of the patient developing pneumonitis and cough would be 0.5%.
Less.
Yeah, so that would be low. There is something called lymphedema from radiation, and if patients have surgery to the lymph nodes to remove lymph nodes plus radiation to the lymph node beds, the chance of lymphedema is up to 20%.
Okay. Now, what is radiation burns?
Radiation burns, that goes back to radiation dermatitis.
Okay.
So that's what happens really is that it's like a localized sunburn to the breast, and the surface layer may peel and come off, and then the underlying dermis is moist. So that's why it's like a radiation burn, because the surface layer.
So
can
it's a temporary
come off.
phenomenon, right?
It is temporary, and several weeks after the radiation that will heal. It's basically like a sunburn. If you go outside, you may come home and you don't have much of of redness, and then you notice redness that evening, and then within a few days the skin can peel and heal.
Yeah, great.
So it's the same with radiation.
We'll take a short break and continue with the part of radiation treatment again in the last part.
Okay.
Please stay back for the last part of the episode. Thank you. Welcome back to the show, Talk with Your Doc. And today we are talking with Dr. Margaret Anthes about role of radiation therapy in the breast cancer. Dr. Anthes, you were mentioning about different side effects of the radiation therapy. And one of this we were talking about is the radiation burns. And you mentioned that it goes away after some days. Is there any treatment which has to be given for the radiation burn?
Well, when patients are getting radiation, we ask them to keep the skin lubricated and clean. So at first we would ask the patient just a gentle moisturizer such as Lubriderm or Glaxol base to the breast. If the breast gets red and itchy or sensitive, we will give the patient some hydrocortisone cream.
Okay.
And that's something that they can even buy over the counter, the hydrocortisone cream. If the patient develops more of a burn or the skin peels a little bit more, we would give the patient Flamazine. And Flamazine is also used just for generalized burns, and we use that for the skin.
Okay. Now, once the whole course of radiation therapy is finished for, like, say, 3 or 6 weeks, what happens then?
Right. So we always warn the patients that the 2 weeks after radiation, the skin reaction may get a little bit worse. So if the patient has concerns, we ask them to call us to come back in, and we'll reevaluate. But generally things get a little bit worse, and then they get slowly better. We book a follow-up appointment for the patient about 4 to 6 weeks after the radiation is complete, to make sure that the side effects have improved, that they're feeling better, and to start the follow-up process.
Okay. And once this radiation and follow-up of 2 weeks after the radiation therapy is complete, then patient goes for the follow-up with their own family physician, or whom do they go to?
Well, what we do with the breast cancer patients is that we follow them at the cancer clinic.
Okay.
Generally for up to 5 years.
5 years.
After their diagnosis. Initially they're seen approximately every 4 months for about 2 years, every 6 months for about 3 years. And then after that, we consider discharging them back to their family doctor, depending on their circumstances.
Right.
We actually have a specialized clinic for discharging them back. It's called the Transition Clinic.
Mm-hmm.
And patients come in and it's generally run by a nurse or nurse practitioner.
Right.
And they get a summary package of their cancer.
Mm-hmm.
The same package goes to their family doctor so that everybody understands in the
Yes.
healthcare team what the diagnosis has been and the ongoing ways of following them.
Right. Now, are there new clinical trials going on at this time in Thunder Bay? What
For-
are clinical trials?
Right. Clinical trials, very important. Patients ask frequently if they're eligible for a clinical trial. And clinical trials are research studies.
Mm-hmm.
And this is how we make advances in cancer treatment in general by having different studies evaluating different treatment modalities and making overall changes in the field. So yes, we do have clinical trials, and we have clinical trials for our breast cancer patients.
So currently they are
And
going on
radiation
at Thunder
trials.
Bay?
Yes, there was a very important trial that we took part in. It was called MA20. It was a National Cancer Institute of Canada clinical trial for breast cancer patients with 1 to 3 positive lymph nodes, looking at the role of radiation or no radiation to the regional lymph nodes. And that study has shown that the patients benefit from having the extra radiation to the lymph nodes. That was a big study that we did participate in. Currently, we have some other studies for precancers.
Okay. So for the precancers, do you give the radiation?
For certain circumstances, yes, for precancers. There's 2 types of precancers with breast. There's lobular carcinoma in situ
Mm-hmm.
from the lobules of the breast, from like the milk glands. And then there's ductal carcinoma in situ from the ducts that drain the milk glands into the
Right.
nipple. And we know that lobular carcinoma in situ is more of a marker for future development of cancer. And we don't give radiation for that.
Okay.
But for the ductal carcinoma, that's more precancerous.
Yes.
And even if it's removed, like the breast cancer, there's still a risk of it relapsing.
Right.
And so oftentimes we radiate the
Give
breast
radiation.
after that. We have a clinical trial for that too.
Wow. Now, how does a patient enroll for clinical trial?
Well, first of all, the doctor has to recommend the clinical trial, and then the patient will meet with a study nurse for that trial, and a consent form will be signed.
Mhm.
Everything is with informed consent, and the
Okay.
patient consents for the trial. And then the patient would enroll in the trial and then be followed very closely. That's the benefit to clinical trials.
How does a patient get information about various clinical trials going around? Is there any website where there's information available?
Well, patients can look online, and all of our patients are screened by our clinical trials department. So when the patient comes in, we know if they will be eligible for a trial. And often before their appointment, we have a little meeting and discuss their eligibility for the trial, and then we present that information to them.
Nice.
Yeah.
Great. This was a great information today. Thank you so much for coming, and we really appreciate your time.
Oh, it was a pleasure to be here.
Thank you. Thank you everyone for joining us the show.